Today is February 18th, 2020. On our agenda today, we're going to get an update on flu and COVID-19. Then we are going to look at the Office of the Legislative Auditor's report on the Office of Medical Cannabis. We'll hear some comments about the addition of macular degeneration to coverage under the Office of Medical Cannabis, and then hear from Leafline Labs. And so with that, I'd like to invite Commissioner Malcolm to talk about the flu in Minnesota and COVID-19. We're also going to have the Hospital Association talk a little bit about how they participate in our public health programs in situations like virus. Members, our pages and sergeants have asked that we speak directly into the microphones. They can't control the volume, and folks are going to have a hard time hearing you if you're not very directional. So welcome, Commissioner. Thank you. Please begin.
Madam Chair, thank you. Members, nice to see you again. Appreciate the invitation. I don't know if this is projecting the slides. I know you've got hard copies at your desks, but it doesn't seem to be projecting on the screens here. Thank you very much. Okay, so it is my pleasure to give you a quick overview of what we know about the fairly newly named COVID-19 novel coronavirus. And the first thing I want to say is, as is always true with something that we've never seen before, it, of course, triggers a higher degree of interest and concern from all of us. And we in public health are always careful to say, we will tell you what we know when we know it, and we will always say, but we can't predict exactly what's going to happen with a novel virus that's previously been unseen. But obviously, this has been really significant global news in the U.S. and here in Minnesota since late December or early January, when the rest of the world became aware of it. I'm going to talk about COVID-19 first, and then give you the influenza update. It's an interesting kind of contrast between something very familiar to us and the public health significance of that, and the new concerns around COVID-19. So these numbers literally change several times a day. So since this slide was produced this morning, there are now 73,000 cases globally of COVID-19 and 1,875 deaths. At least that was as of a few hours ago. It's very notable that of the 25 countries reporting any cases at all, the vast majority of the cases and almost all of the deaths have been in China, and Hubei province as the epicenter, as we all know. Only 15 cases so far have been confirmed in the United States. We do know that some of the passengers on that very unfortunate cruise ship, the Diamond Princess, are Americans and are being brought back to the U.S. over the coming days. Those who are symptomatic will be taken directly to medical facilities. Those who are not symptomatic will be quarantined at bases, so they will not be coming directly back to any states that aren't already set up for these sort of large-scale quarantine efforts that we've seen with repatriated Americans coming back from China in recent weeks. So we do expect these numbers to continue to change, but it is notable that there just has not been widespread increases in these numbers, not only not in the U.S., but in most of the other countries reporting. What it appears about COVID-19 from how easy is it to spread and how dangerous is it, is that some of what we know from the other coronaviruses that have been circulating, this appears to be, at this point in time, actually less lethal than SARS and MERS. And that's a good thing. And it looks to be not too dissimilar from the flu in terms of its lethality. Might be a little bit easier to spread than SARS and MERS, although that's still a really rapidly emerging picture based on more and more reporting coming out of China. We do know that, as is true with most of the other respiratory viruses in the coronavirus family, those folks with underlying medical conditions and older adults seem to be more susceptible to having a more severe case of COVID-19. But always, and we know this from the flu as well, occasionally there will be a perfectly healthy person that has a very serious reaction to COVID-19. So it's not it's just never the case that a blanket statement can cover all contingencies. So as I mentioned, there are no confirmed cases in Minnesota and have been none since the outbreak began. We have had a few potential cases that we have shared samples with the CDC, 3 to be specific, and those all came back negative for the COVID-19 virus. So no confirmed cases in Minnesota. The health department and our partners are working hard to get information out to all the partners in the public health response effort, including the hospitals and health systems from whom you'll hear directly. But it's very important to us that we're communicating accurately and frequently with local public health agencies, with our provider community, particularly with Chinese Minnesota groups, with folks at the University of Minnesota and other institutions of higher learning that have potentially large cohorts of Chinese students and staff, our Minnesota international corporations that have folks traveling all over the world and relationships with China. As well, K-12 schools are asking for an increased level of information, as they just want to be sure that they're prepared should there be cases in Minnesota. So we're in constant contact, literally multiple times a day, with lots of different stakeholders. We do continue to get a lot of calls every day from providers and from the public, people with respiratory symptoms and any history of any travel anywhere. Folks are understandably concerned just that this virus might be present wherever they've been. Most typically, and certainly that's part of what makes this difficult, is with the amount of other respiratory illness circulating in our community and circulating globally, it can be hard for people to distinguish between symptoms of the flu or other common respiratory illnesses and the new COVID-19, which is why at this point in time the only definitive way to rule out whether something is another respiratory illness or this virus is for that specific lab test that's been developed rather remarkably quickly by the CDC with the genetic sequencing that they have had from the virus itself. To this point in time, only the CDC has been able to do those lab tests. We have, at the Minnesota Department of Health and other state public health labs, also been given test kits to test for this virus, although there was an issue with one of the reagents in the first test kit. So we are not yet doing the testing here in Minnesota, but we will be I anticipate the very near future. In addition to the cases we know of and the quarantine that happened with the Americans that were repatriated from China, all air travelers from China are now going through 11 screening airports. Ours is not one of them at MSP. And all travelers from Hubei automatically go to a quarantine location for 14 days. Travelers from other locations in China are asked to self-quarantine for 14 days. And health officials are given information on any recently arrived travelers who are not going to quarantine. So there are folks, Minnesotans or visitors to Minnesota coming here from other locations in China who are in this self-monitoring status. We are given daily lists of passengers who are arriving for us to be in contact with. So we know who's in this situation. We give them information on what to monitor. We're in touch with them a couple of times a day about emergence of any symptoms or not. So it's a pretty robust surveillance effort that we have. And in addition to these activities that are targeted specifically at travelers from China and elsewhere, just one of the real strengths of our public health system in Minnesota is the really good surveillance network that we've established with our healthcare providers all over the state. Our infectious disease reporting laws serve us well. Our partnerships with the provider community serve us well, that folks don't hesitate to call if they are having questions or concerns about symptoms. So we really rely on that system that's functioning 24/7 all the time. There are interesting diseases reported to us on a daily basis. This is something we do literally every day. Not always with a novel virus that's never been seen before, but we really do feel that we've got a very, very strong surveillance system in place. So the protective recommendations for the public from the CDC are really the basics. It's just exactly, if one's worried about protecting themselves from COVID-19, it's really the same good old standard precautions that are advised for any respiratory infection, that it's very helpful to protect yourself and others to stay home when you're sick. Always cover your cough and wash your hands really well, by which we mean really, really well. I watched a video the other day of proper hand washing technique and realized that I could buff up my technique a little bit too. You're really supposed to wash very thoroughly, nails included, and it's very, perhaps the best single thing we can do. We at the health department do periodically take a look at whether it is appropriate to recommend, and groups are often asking us, several groups have asked us, should we cancel this or that event? At this point, we are not making any recommendation that there's any need to cancel community events, whether that's in the Chinese American community or anywhere else, that we have no indication of a virus circulating here that would lead us to recommend cancellation of events. We absolutely do continue to monitor the situation. There are literally multiple calls every day between the CDC and our epidemiologists, and at least 4 briefings a week with state health officers. So there's a constant stream of information flowing, and we absolutely commit to you and to the public that we will share new information whenever and as soon as we get it. So one question we've gotten is, what about face masks? Should we all be wearing face masks? And really, the best use of face masks are by ill people to prevent them from spreading the infection, and by healthcare workers who are providing direct care. For the rest of us, face masks are not recommended as a preventive measure. And actually, we're beginning to get a little concerned about the supplies of these kinds of personal protective equipment. So any stockpiling or attempts for people to kind of gather these things and save them do raise potential concerns about the availability for those who truly need the masks. So again, another reason why we want to assure the general public that we don't all need to be wearing masks. So that's kind of it on the COVID update. I can go into influenza, or we could have the hospital association speak, whichever you prefer, Madam Chair.
Why don't you give the influenza update, and then we'll move to the hospitals. Thank you.
Okay.
And, Senator Kiffmeyer, and then Senator Jensen to this point.
Okay, to this point, I just happened to step out, and I thought I was in the swing of things. On the protective measures is where I was going.
Yes, Senator Kiffmeyer,
That's okay?
anything that we've covered so far, let's
good.
do those
Okay.
questions.
I noticed in here, which I thought deserves some emphasizing, in regards to face masks. I've heard about this a little bit before. Some are effective, some are not so effective. They're effective for the first hour or a variety of those things. But I thought it was interesting at saying here, best used by ill people to prevent spreading infections, since it's a droplet spread, the more you can keep them. I was also noticing cover your cough. There was a young lady recently, and when she coughed, she tucked her mouth into her little jacket and coughed into her clothing. And I was wondering, cover your cough is one thing, but then it's on your hands, and then you touch your face or you touch something, versus the covering, coughing into your clothing. And so I just know we have an opportunity right now to just talk about these things, maybe just briefly.
Commissioner.
Madam Chair, Senator Kiffmeyer, you're right. I could be a little more precise. By cover your cough, we literally mean not with your hands, with a handkerchief into your elbow, into the inside of your jacket. You know, not pleasant things to contemplate for your clothes, but far better than getting the germs all over your hands, when it's really easy then to touch a knob, shake somebody's hand, touch your eyes. That is the quickest route to transmission that we know. So, yes, cover your cough really means, you know, with something other than your hands.
Thank you.
Thank you. And Senator Jensen.
Thank you, Madam Chair. Probably 4 questions, and thank you for being here, Commissioner Malcolm. First off, I did not hear, and you maybe covered it because I was a little late, surface life of coronavirus in terms of, you know, being spread by a respiratory droplet, and you've got on some hard surface. How long do you think that surface life is?
Commissioner.
Madam Chair, Senator Jensen, I'm sorry I didn't think to bring one of the infectious disease folks with me today. I don't think anyone's in the audience. I can't give you a precise answer like they could, but my understanding is it's a rather short-lived matter of hours.
Second question. Thank you, Madam Chair. I'm sure that you're monitoring someone, but do we have any evidence at all that we're seeing spread through animals in some sort of a zoologic infection? Because I know that coronavirus can be spread through animals. Have we had any concerns in that regard?
Commissioner.
Madam Chair, Senator Jensen, I've not heard of any animal spread concerns in the U.S. Or other countries. Certainly that was thought to be a factor in the origin of the outbreak in China was animal transmission and then animal to human.
Third question, Madam
Senator
Chair.
Jensen.
Third question would be, in terms of vaccinations, you know, when I think back to the Ebola virus and we saw the strains and we saw number 27 and things like that, are we doing anything? Because there is a lot of similarity to the SARS virus with this. And if you look at the death rate from this, we're getting like 1 out of 40 or 1 out of 50 people dying from the coronavirus, while in 1918, it was like 1 out of 10, 1 out of 15. And I think in 1918, 25% of the world's population was involved. In order for that to be the case today, we'd have to have 2 billion people involved. And, you know, we're not even to 6 digits, if you will. So I guess the question would be vaccination production. Is there anything going on in that regard?
Commissioner.
Madam Chair, Senator Jensen, yes, there is. And you're absolutely right that the prior experience with coronavirus gives us a head start on that. I've heard speculation from different quarters that vaccine production would probably, there probably wouldn't be a reasonable supply of vaccine or even a targeted supply of vaccine until next spring. But that's still a pretty fast track for vaccine development.
Madam Chair?
Senator Jensen.
Efficacy of Tamiflu or oseltamivir versus the coronavirus. Any studies on that?
Commissioner.
Madam Chair, Senator Jensen, I'm not aware that we know anything about Tamiflu's effectiveness yet. That I certainly can ask that question and get back to you. I do know new antivirals are being worked on already with the genetics from this particular virus.
Last question, Madam Chair.
Senator Jensen.
Thank you. Commissioner Malcolm, a lot of patients ask me about this. A lot of people here ask me about this. What will be the impact as we move into warmer weather? You know, once we get into March, April, what is that? What will that, and what do you anticipate that will do to the coronavirus?
Commissioner.
Madam Chair, Senator Jensen, so far it does look like this, COVID-19 has similar characteristics to other coronaviruses that do have a seasonal effect, and in warmer weather we would expect to see that tail off. The unknown is whether this virus will actually burn itself out as SARS did, or whether it will become a circulating strain like the other 4 or 5 coronaviruses that are just with us now and need to be managed.
Thank you. And I have Senator Nelson, Senator Rosen, and then Senator Klein. So Senator Nelson. And members, remember, we haven't gotten to influenza yet, so.
Thank you, Madam Chair. What was your last comment? Remember what?
We haven't gotten to influenza.
Thank you. Thank you, Madam. Thank you, Madam Chair. Commissioner, I have a few questions. One has to do with a pandemic. And there's been some discussion recently that this is a pandemic. It should be should be classified as a pandemic. So I'd like to have you weigh in on that a little bit. Maybe why it isn't at this point, but more importantly, how would our actions be different if it were a pandemic, and how can we better prepare our constituents and our state for what I believe there will be a case or cases here. There were 2 suspected. And then the last thing I'd ask you to comment on is I believe I saw a report last night about a Minnesota couple who were on one of the cruise ships that were evacuated in a cargo plane full of, so a place where a virus could spread quite easily. And so kind of talk about how you're containing that. So the pandemic, also the Minnesota cases to come, and how we can best prepare.
Commissioner?
Madam Chair, Senator Nelson, in terms of the technical definitions of pandemic and when does something tip into that level, again, I'm regretting I don't have my epidemiologist sitting right here to give you a better answer than I can. But I think given the fact that this disease does not seem to be spreading rapidly outside of certain very concentrated population areas, it is not considered, it's certainly not pandemic in the U.S., and pandemic really indicates that it is becoming a potential for global large-scale spread, and that does not appear to be the case here. With respect to our readiness, though, for pandemic, we have pandemic flu plans already developed and already exercised periodically with the healthcare community and the public health community. So you're absolutely right. We do expect, as a matter of course, that something will happen that will be widespread in nature, and that it's incumbent upon us to have plans in place now for that should it happen. And we certainly can give you a briefing on what the pandemic flu plan is for Minnesota at a later time. Might be interesting. But I think we look at each one of these, frankly, as another opportunity to test our assumptions and to exercise a little bit components of the plan. And again, at the present time, even if we do have some cases in Minnesota, there's no reason at present to believe that this is going to become widespread, circulating in the community. That so far our efforts to contain it through very, very close contact monitoring and self-isolation of folks is succeeding in keeping it from spreading.
Thank you.
Madam Chair.
Senator, quickly, yes.
Yes, well, I was wondering, assuming that there probably will be a case or 2 here, we have to, are there lessons learned that we can from, it kind of reminds me a little bit of the Ebola virus and how there was the monitoring and such, and I just am wondering if you can give some assurance in how this will be handled and what we've learned.
Commissioner?
Madam Chair, Senator Nelson, yes, we too consider each of these things to be an opportunity to learn, and I think perhaps the folks from the Hospital Association might also have some good insights for you on how the lessons from Ebola might have carried over. As I mentioned, we are treating this from a communication standpoint as though it could turn into something of a larger scale. Just to be ready in case it does. In terms of you might have come in after I was talking about we do expect the numbers to increase as a result of the folks coming back from the cruise ship. Anybody coming back from that situation is not coming directly back to their home states. They'll go through that same quarantine and self-isolation procedure as the other U.S. citizens who were brought back from mainland China.
I'll hold off with my questions, Madam Chair.
Senator Rosen and then Senator Klein. And if we can speak directly into the microphone, we're having a little trouble with microphones.
Absolutely. Thank you, Madam Chair. Thank you, Commissioner. And I'm sure a few of us around the table remember the pandemic bird flu and Senator Berglund's approach to that, and MDH's request, I think, was approximately 12 million, 25 million? It was a lot of money. I'm wondering, with what we have coming ahead of us, are there measures that are going to be needed on our part for the Department of Health to address this? Or the pandemic bird flu was a big chunk of money. That was 15 years ago? 12 years ago? It was a long time ago.
H1N1? Yeah, about
It
that.
was a long time ago.
So,
So just
Commissioner,
wondering if there is some measures that Department of Health is going to need.
nice to
some
have
help with.
the Finance Chair
Yeah.
on the Health Committee, Commissioner.
Yes. Thank you, Madam Chair. Senator Rosen, thank you for that question and for thinking ahead. We are actually already have authority from the feds to repurpose some federal grant funding for this purpose, should it be needed, and we're anticipating some direct funding from the federal government to help. We also, thanks to the legislature, do have a small but very, very helpful public health emergency response fund here at the state level that we tapped previously for measles, and are kind of setting things up to be able to tap that fund should it be necessary. At the present time, just based on the numbers that we're seeing, we're not anticipating that we would hit any resource requirements that we couldn't handle through federal reallocation or through the existing state fund.
Madam Chair?
Thank you, Senator Rosen.
Thank you, Madam Chair. And Commissioner, was that appropriation years and years ago, that fund, was it set up for that fund? I cannot remember the parameters of it.
Madam Chair, Senator Rosen, it was before my time, but I don't think it's that old. I think it's only 5 or 6 years old.
And Commissioner Senator Rosen, I think it was 2017, we put some money into a special fund for public health emergencies. It was in the Dayton administration, previous commissioner.
Madam Chair, I do remember it was Senator Berglund who, that was a large appropriation, very large back then. Yeah.
Madam
Senator-
Chair, if I might, I would like to get back to Senator Rosen on what that H1N1 experience was and what the financials were.
Thank you. And Senator Klein.
Thank you, Chair and Commissioner. One of the modes of transmission that became a phenomenon during the SARS outbreak was patient-to-healthcare provider transmission, and generated some anxiety within the profession about, caring for patients with respiratory illnesses. And I think we've seen anecdotal cases that may be a phenomenon with this virus as well. Is the state of Minnesota, as part of your contingency plans, thinking about the healthcare workforce and specific protections? I happen to believe that healthcare workers take an oath in some cases and have a moral obligation to continue caring for patients despite personal risk. But what measures are contemplated to protect our healthcare workforce?
Commissioner?
Madam Chair, Senator Klein, that CDC and the Health Department have given guidance to healthcare workers for what proper protocols for caring for suspect cases or known cases. And at the present time, basic kind of personal protective equipment seems to be appropriate. Again, I think the Hospital Association representative could perhaps address what's happening inside the healthcare systems with respect to advice to workers. But you're absolutely right. The healthcare workers are on the front, literally the front line of defense, and are at risk because of the intimacy of that care for infected persons.
And Commissioner, we asked for an influenza update because in all of the COVID-19 conversation, we forget something that might actually impact Minnesotans more than the COVID virus.
Right. Thank you, Madam Chair. So this again is a great case of what we know being something that we just get kind of used to, the level of flu activity in any given year in the country and in the nation. And so far in Minnesota, we had a flu season that started a little earlier than usual, and it started with influenza B early in the season, which is an unusual pattern, which tends to be a little more dangerous to younger people. We are getting sort of a second wave now of influenza A and B co-circulating at the same time. So I wouldn't be doing my job if I didn't say it's still not too late to get your flu shot if you haven't. So far this season, we've had 52 deaths from the flu, which is not a terribly unusual number, but again, to put it in context, and over 2,000 hospitalizations with, as is typical, older population tends to be at greater risk. These are some pretty startling numbers, though. 757 outbreaks of influenza-like illness in K-12 schools. Some of the schools reporting as high as 25 or even 30% of their students out at any one time. So certainly it's a big health concern. It obviously also has a very, very significant impact on our schools. Almost 50 outbreaks of influenza in long-term care facilities is a very important place to put our attentions on infection control and prevention. And we are seeing that the percentage of influenza positive tests remain pretty high, elevated at about a third of samples that are submitted coming back positive for the flu. So those are some pretty significant numbers, not out of the norm of what we see for influenza in Minnesota annually, but just, again, an interesting contrast with the coronavirus.
Thank you, Commissioner. I'm going to ask, Senator Jensen, influenza questions.
To the point. Thank you, Madam Chair. Commissioner, I just want clarification. One is, what do you define an outbreak as?
Commissioner?
I think the school outbreak data, I want to say, is 10% of the students.
Thank
Senator
you.
Jensen?
And the second question, when you say the percentage of influenza tests that are positive remain elevated at 33 to 36%, is the underlying implication there that if we have 100 people diagnosed with influenza, that 33 of them will test positive and 67 would test negative, but clinically we're calling it? Or are we saying that we're calling 100 influenza cases and we're not testing all of them, but we're testing, of the ones we're testing, we're doing 33%? Because I could see three different scenarios. One is you have 100 patients with the diagnosis of influenza. None are tested, but all match up clinically. That would be one match. The other one would be all are tested and 33% have a positive flu test and 67% have a negative flu test. And then the last one would be the hybrid, where you would have 100 people diagnosed with it. Some would have been tested and some would not. Can you help me understand what those numbers mean? Because it's possible that we may be calling things influenza that may simply be rhinoviruses or things like that. Because oftentimes we do have a bias as we make our diagnoses. Sometimes the bias is more insidious in nature. Sometimes it's due to coding. Sometimes it's due to other things.
Commissioner?
Madam Chair, Senator Jensen, excellent questions, and I will need to get back to you on which of those three scenarios it is. That's an excellent question. Thank you.
Okay, thank you. And I'm going to ask Tanya Daniels from the Hospital Association to come up and give us an update on what the hospitals are doing to participate in both influenza, but also the coronavirus. As Senator Nelson mentioned, when we went through Ebola, the hospitals played a really critical role and gave us a good education on their partnership with MDH. So please proceed.
Thank you, Madam Chair, and good afternoon, everyone. I'm Tanya Daniels, Vice President for Quality and Patient Safety at the Minnesota Hospital Association. And just very pleased to be able to share how Minnesota hospitals and health systems are proactively addressing and preparing for emerging infections such as COVID-19. And we work very closely with the Department of Health. And very similar, one of the lessons learned from the Ebola was how we can partner closely with the Department of Health, provide good communication through regular calls. With Ebola, we were having calls twice a week. With COVID, we are now having calls weekly with healthcare systems and key stakeholders. So those started the week of January 24th. They will go through March, and we've had such great interest, anywhere up to 250 attendees on those conference calls and webinars. So the Department of Health, in alignment with CDC guidelines, they provide the epidemiology, the clinical state of this, but then more importantly, how things can be recognized and tested and how to handle this. So as you can imagine, it's quite as frightening as what Ebola was. There was a lot of fear. I think our Department of Health has done a great job in bringing science and clinical world to this, that it's not considered a highly contagious condition, that this would be treated more like the flu. So with these participants on the webinars, there's great interest, so not just the hospitals and health systems. We've had nursing homes attend, public health departments, counties, schools, tribal health service, healthcare coalitions, the emergency medical services, and our bordering states as well, the Dakotas and Wisconsin. And as Commissioner mentioned, we do not have any confirmed cases yet in Minnesota. There has been one in Wisconsin and 14 others throughout the U.S. and 8 in Canada. So we're watching this closely and very confident that our health systems are prepared to care for these patients. And again, working very closely with the Department of Health. They've been very hands-on, that if there's any suspicion that they have a hotline, and I think Commissioner mentioned that they are receiving calls regularly to help identify and screen and how to handle these patients. So I mentioned that these patients are treated more like flu patients, so they would have personal protective equipment in addition to a specialized face mask called N95. And at this point, there's not the concern in terms of the number of those being available. We do have a commitment from the manufacturers that they're looking into this, and with our current numbers, we're assured that our numbers are on track to secure the proper PPE for that. Minnesota does have a strong disease surveillance system in place with partnerships with our hospitals and clinic systems, as well as state and local health departments. MDH has been an exceptional resource to hospitals and health systems to screen and rule out any potential cases. And I think that's the important piece, is getting them early on and catching that early and making sure to isolate them within the proper place within the hospital in that negative airflow room. And hospitals and healthcare providers are trained to manage infectious diseases, including new infections such as COVID-19. And that is part of the CDC guidelines in terms of how healthcare workers can protect themselves and keep them safe as well. And as you've seen, there are more patients that are affected with the flu this year. So while we don't have an ask right now, it's more that we are here to be a resource for you and also the healthcare hospitals and systems, and with our partnership with MDH. Madam Chair.
Excellent. I want to thank both of you. Senator Eaton, we don't very often talk about how important our public partners are, our private partners are with our public health system. So thank you for being part of this presentation. Senator Eaton.
Thank you, Madam Chair. I don't know whether Commissioner or Ms. Daniels would answer this, but I was watching some of the people who were put in isolation or whatever, and I'm wondering if we have any kind of mechanism here in Minnesota for people to provide support or, I mean, they seemed quite distraught. They were, they were not being able to interact with anyone for like 14 days, and some of them were stuck in a stateroom in a cruise ship, which are not huge. I'm just wondering if we have any kind of mechanism to deal with people and provide some support.
Commissioner?
Madam Chair, Senator Eaton, we do take it as our responsibility when folks are self-isolating, or especially if they're being quarantined on our direction, to assure that they have what they need by way of shelter, food, medical attention. So we don't leave them just by themselves. You're right about just the psychological distress of being isolated for that length of time. That can be very challenging. So I think being in touch with them, though, and checking in very frequently, and they always have our number. They literally can call us at any time as well.
Thank you, Senator Nelson, and then Senator Klein, and then we'll wrap up this portion.
Thank you, Madam Chair. Just a quick question regarding kind of, and I'm not sure who would be best to answer this, but I'm just wondering about the fatality rate of these different viruses. Like, what is the flu fatality rate, the COVID-19 fatality rate? We've talked that it's a bit like SARS or even MERS. I think that one was a 37% mortality rate or fatality rate. But if you could kind of just put this all in perspective, maybe these four viruses that we've been speaking of, what is the fatality rate of the flu, the coronavirus, MERS, SARS, just kind of put them in perspective for us.
Commissioner?
Madam Chair and Senator Nelson, I think, regrettably, I don't have that table with me right at the moment. I think that sounds high for the MERS fatality rate. I think none of these things are as contagious or as dangerous as measles, for example. But I think the fatality rate for COVID right now appears to be about 2%, seems to be holding at that level, which is flu affects different groups differently. So population-wide, flu would be less than 2%, but in populations with underlying health conditions, it might be similar to that.
So, Madam Chair, my comments, right, you're right on the measles vaccine, that is the most contagious thing on the planet. But MERS, according to the Star Trib, or Pioneer Press, MERS had a 37% fatality rate, SARS 10%, and as you said, the coronavirus 2%, but flu 0.1%. And if you feel
I
that's
think,
somewhat
Senator
accurate.
Nelson, Commissioner, if you have a table from your epidemiologist, if we can get it to staff, we will forward
That'd be great.
that.
Thank you very much.
Absolutely,
that.
thank
Thank
you. Senator Klein.
Thank you, Madam Chair. I'll be brief, and I don't have a question so much as just a hopeful request from both of the witnesses that, again, on my point about the healthcare workforce, anticipating that there may be cases and will be cases in Minnesota, and the history of transmission to healthcare workers, I would encourage you to develop a series of concrete recommendations for how to protect our healthcare workforce, and so that they're not excessively, protective, wearing face masks when it's not warranted, for example, but also excessively risky. We have the advantage today that we didn't have during the SARS virus of a much more sophisticated isolation system within hospitals and institutions that you've referenced, and so healthcare workers are more knowledgeable about various gradations of isolation and so forth. So you've got that resource to work with, and hopefully I hope you can come forward with some recommendations.
Thank you, Senator Klein, and thank you to both of you. Members, we're going to move on to the Office of the Legislative Auditor had a report on the Office of Medical Cannabis. So, Commissioner, if you'd like to stay at the table, we do have time planned for a response from you, and then we're going to move on to a discussion about the addition of macular degeneration. Welcome, Ms. Bombach. If you could make sure you're speaking directly into the microphone. We're having some microphone challenges.
Certainly.
And members, there is a copy of this presentation in your packet, printed in color. There's also MDH summary response. So as we're going through each of these items, having those reference documents will be helpful.
Madam Chair and members, I'm Valerie Bombach. I'm an audit director within the Office of the Legislative Auditor. Todd Pisarski and Kelsey Carlson from our office also worked on this audit of the Office of Medical Cannabis. So why did we do this audit of the medical cannabis program? The program is relatively new.
Ms. Bombach?
Yep.
I know it's difficult. If you could make sure the microphone is directly in front of you. Our members are having a little trouble hearing you.
Okay, I hope that's better.
Better, right there.
Put
Thank
that
you.
up there. Okay. Shuffle this over. So why did we audit this program? The medical cannabis program is relatively new, and since its creation in 2014, OLA had not audited the program or technology systems, mostly because it is a smaller program. However, there is now increased enrollment and demand for medical cannabis. The Office of Medical Cannabis within the Department of Health oversees the medical cannabis program. And this office enrolls patients and healthcare practitioners. It verifies the eligibility of caregivers for patients and also collects patient registration fees. MDH also oversees 2 in-state manufacturers. They are Leafline Labs and Minnesota Medical Solutions that the department approved to cultivate, produce, and dispense medical cannabis for Minnesota's program. Under federal law, cannabis is classified as a controlled substance and cannot be transported across states. Because of this federal restriction, the program requires the use of product that is grown within Minnesota. The 2 manufacturers also must each contract with a qualified laboratory approved by the department to test their medical cannabis product for various elements such as content, contamination, and stability. Beginning in April of 2015, the department approved 2 laboratories to do this. They are Aspen Research Corporation and Legend Technical Services. This map shows the manufacturer service regions and dispensaries as of July 2019. At that time, each manufacturer was limited to 1 manufacturing location and 4 regions within which it must operate a pharmacy dispensary to provide medical cannabis. So medical cannabis is dispensed through the manufacturer's dispensaries that it's not available at your local Cub or Walgreens pharmacy. What is medical cannabis? It is derived from the cannabis plant. In Minnesota, it's administered in the form of liquid or pill. It's vaporized with the use of oil or liquid, or it's in some other form that's approved by the Department of Health. It does not involve the use of dried leaves or plant form, and it may not be smoked. So this drug is available to Minnesota residents whose healthcare practitioner certifies them to be suffering from certain conditions, for example, cancer, multiple sclerosis, or seizures. For this audit, our objectives were to determine whether the Department of Health had adequate internal controls and complied with significant legal requirements. And for our work, we did not conduct a comprehensive audit of the manufacturers and laboratories or their legal compliance. We really did focus on the Department of Health. What did we find? We looked at this new program in light of the increased enrollment and demand for medical cannabis. And overall, we concluded that the oversight foundation, the processes and systems really needed to be tightened up before any large-scale expansion. We concluded that the Department of Health generally complied with most of the legal requirements that we tested, although we noted some exceptions. However, we also concluded that the department's internal controls over the program were generally not adequate. And I will walk through those weaknesses and exceptions in the following slides. First, I'll start with our findings related to authorizing patients. When certifying new patients for the program, the department must validate that the patient's healthcare practitioner is eligible and that their license is active and in good standing. The Office of Medical Cannabis does verify the status of a practitioner's license with the respective board the first time the provider and the first time OMC enrolls a practitioner for a new patient. However, the department staff do not re-verify when the practitioner approves another patient for the program or during annual renewal for the patient. So if the practitioner is already in the program registry, staff do not recheck to determine if the license is expired or lapsed. It does verify whether there have been any disciplinary actions against the practitioner. Next, for the program, a patient may be allowed to have a caregiver, a parent, or a legal guardian assist with obtaining and administering the drug. However, we found that the department lacks adequate controls to confirm the eligibility of parents or legal guardians and their relationship to the patient. And these exceptions that we noted were primarily due to weak documentation standards, but also limitations within the medical cannabis registry system to hold the documents. For example, the registry doesn't maintain a log of events, and there's limits to how many documents it can keep. We have several recommendations to the Department of Health to address these particular findings, and in the interest of time, I just want to focus on the second item on the slide, which relates to authorizing healthcare practitioners. We think that the Department of Health should amend department rules to require a practitioner to notify it of a change in license status or when they discontinue care of the patient. Healthcare practitioners who choose to participate in the program have several obligations. One, they have to agree to provide continuing treatment for the patient for the qualifying condition. They recertify the patient, and they also have to provide patient records on an ongoing basis. And so we think under this situation, the practitioner also should have to notify the department of a change in license status or when they choose to stop treating the patient. Our next findings relate to fee collection and payment processing. Under the program, it is supported through appropriations, but also fees that are paid by manufacturers and patients. The patients have to pay an initial enrollment fee as well as an annual fee. Most of the patients pay a $200 fee. However, the fee is reduced to $50 if the patient receives certain types of income, and these, the income is defined in law. And these include Social Security disability or supplemental security insurance payments, or if the patient is enrolled in medical assistance or Minnesota Care. However, we found that the department incorrectly charged the reduced fee of $50 for other patients too that were not specified in law. And these included patients who the Office of Medical Cannabis had identified as a disabled veteran, and also people who were at one point disabled, but because they had reached full retirement age and now receive Social Security retirement benefits, they were no longer entitled to the Social Security disability that was an exception defined in law. We have two recommendations to the department in how they collect and reconcile fees, but I want to focus on a recommendation to the legislature, which relates to the fee rates. Again, we think that, according to law, the Department of Health should not have granted the reduced fee rate to some patients. And to partially address this, we think that the legislature should consider whether disabled patients who receive Social Security retirement benefits should pay a reduced fee, and if so, amend state statutes accordingly. Our next findings relate to tracking and testing medical cannabis, and this was really the area of concern for our audit. First, we found that the Department of Health did not ensure that each of the two manufacturers had a formal contract with a testing laboratory as required in law. Testing the medical cannabis helps identify contaminants and ensures that the end product contains the appropriate dosage as prescribed by a pharmacist to the patient. We noted that Minnesota Medical Solutions did not have a formal contract with either laboratory until July 2018, which was 3 years later, and Leafline Labs did not have a formal contract until May of 2019, which was after we began our audit. I want to emphasize here that the manufacturers were utilizing the laboratories, and the laboratories were doing the testing, but there was not a formal contract to ensure that if there's any adverse reactions, there is a means of taking corrective action. The department, we found, also did not have adequate controls to ensure that manufacturers accurately tracked and tested their product prior to sale. And again, here we're focusing on what the department's controls should be. There are a number of requirements in law regarding how each manufacturer must assign and report to the Office of Medical Cannabis certain identifying information, such as a unique number. And a unique number helps with inventory tracking of medical cannabis from its cultivation through production, testing, and sale to a patient. The tracking number also helps ensure a product has been adequately tested prior to dispensing and allows for follow-up in the event of a patient's adverse drug reaction. It also facilitates inventory accounting to help detect diversion of medical cannabis for illegal purposes. And so there were a number of controls in place where we felt that the department needed to strengthen its processes and requirements in its review of what the manufacturers were reporting. We want to emphasize that compliance with the state reporting requirements and effective internal controls for tracking the medical cannabis is important. For example, during our audit period, the department issued an administrative penalty order to one manufacturer, that was Minnesota Medical Solutions, for dispensing medical cannabis that had not passed potency testing prior to sale. The department made this finding as a result of an investigation that was initiated from a patient who had reported they had used and experienced an adverse reaction from MMS's product. For our last finding, we concluded that the department did not have adequate controls to help prevent and timely detect diversion or loss of medical cannabis by a manufacturer. The manufacturers are required to have preventive and detective internal controls in place, and the department is required to oversee the manufacturer's compliance with law. As part of its oversight in law, the department can conduct what are referred to as independent examinations of the manufacturer's business and financial affairs, their practices, and the conditions of the entities. And it can also hire subject matter experts, such as experts in security controls and surveillance, to do this. We did find that the Office of Medical Cannabis staff conduct unannounced inspections of manufacturers' facilities to review their record-keeping, inventory, and premises. However, the department did not require what would be a comprehensive independent examination of either manufacturer until March of 2018, which was nearly 3 years after they began selling medical cannabis. We think here that the independent examinations can help identify potential risks, and it can help the Department of Health inspectors target these areas to monitor compliance with legal requirements. Here again, we think that had there been more rigorous oversight of manufacturers' compliance, the Office of Medical Cannabis may have been able to detect what was a serious compliance issue that occurred at one of the manufacturers, MMS. And so here I'm just going to describe what was in a court documents and information from the court records. In mid-2016, the Office of Medical Cannabis was notified by a former employee of MMS that 2 MMS officers had previously transported MMS product across state lines to New York, which is a violation of law. In this case, a Wright County prosecutor subsequently charged the 2 MMS officers with intentionally transferring medical cannabis to a person other than allowed for in law. These 2 officers did subsequently leave the manufacturer, and this case was subsequently disposed of through an agreement approved by a Wright County judge. These last recommendations that we have are to the department and relate to tracking and testing medical cannabis. Here we think that the Department of Health should ensure that each manufacturer maintains a written contract with a laboratory to test their medical cannabis. We think the department should improve controls over tracking and testing medical cannabis in several areas. For example, to require accurate and complete reporting of tracking numbers and other information to the department, and to routinely review the medical cannabis registry data for accuracy and completeness. Lastly, we think the department should also conduct more frequent examinations, and these examinations should be comprehensive, financial and inventory in nature of the manufacturers to help prevent and timely detect diversion or loss of medical cannabis. And with that, Madam Chair, I'd be happy to take questions.
Thank you, Ms. Baumbach. And I know, Commissioner, you prepared a response, so we'll go to your response and then questions from members. But keeping in mind the department has provided us with a chart of actions that they are taking and then things that we can move as a body. Senator Kiffmeyer, while MDH is preparing the response.
Right. You referenced the chart, and my question was to specifically, there are 4 different legislative action items that are on here. Excuse me, is that language drafted? Is it being introduced?
Senator Kiffmeyer, I've requested that it be drafted, and if you are interested in authoring, we can give you that task, but I think Senator Coran might be interested as well.
He's welcome to carry that. I just want to be sure it was covered.
Commissioner.
Madam Chair, members, thank you very much. If I could have assistance switching the monitor back, please, thank you. And I've asked Chris Tholkus, who directs the Office of Medical Cannabis, to join me at the table for your questions. Thank you so much. Let me just start off by saying thank you to the auditor for another thorough report. I can be fairly brief here because in general, I think we couldn't agree more that internal controls, strong internal controls are necessary. And we, in fact, have been working hard to strengthen internal audit as a function at the department for the last couple of years. In particular to this program, our beefed up internal audit program actually identified many, if not almost all, of these same issues. And a lot of work was done during 2019 on these very issues, which is what leads to the progress report in that chart that you have. And as the auditor noted, this was a review of July 2016 through December 2018, so the report, quite understandably, does not reflect the improvements made in 2019, but we have, I think, tried to respond through the chart with a more current picture of operations. So there were the 7 findings that Ms. Bombach took us through and 12 individual recommendations, which you see listed in that table. And we certainly agree that more work is needed, and as noted, one particular recommendation with respect to the charging of appropriate fees. We have talked with Chair Benson and Chair Kiffmeyer from the Audit Committee perspective and agree that it would be good to clarify the legislature's intent. We had quite a discussion about that in the hearing in the Audit Committee, Oversight Committee, and agree that it would just be important to have that specificity in statute. That is really the only policy change that we're seeking this year. The big recommendation around the importance of being able to track in much more specific detail what's going on within the manufacturing process would require a seed-to-sale tracking system, which the governor's supplemental budget won't be decided until after the next forecast, but we're anticipating that that seed-to-sale tracking system request would not be forthcoming until the next biennial budget. However, we do have sort of a partial solution with the contract renewals last December. A couple of the auditor's recommendations were addressed in the renewal of the contracts with the 2 manufacturers, including giving us read-only access to the seed-to-sale tracking systems that the manufacturers use. That's not quite as good as having our own system, but it does allow us some greater visibility into their processes. So I think I've already pretty much said that, what's on this slide, that we do feel that the controls have been significantly strengthened, can be stronger still. That future technology upgrade would help a lot with that core finding of the auditor, with which we agree. And on the policy issue, the eligibility for lower enrollment fee, we are appreciative of your interest in helping us address the statutory clarity of that, and we'll look forward to rapid resolution on that front. I think that is it for our response to the report, unless you have questions.
And specifically to the report questions from members, we will have some bill language before us to resolve some of these issues. Senator Kiffmeyer.
So thank you very much, Commissioner. Appreciate that update. In regards to the seed to sale, in my district and touring different companies, one of them made medical parts for use in knee replacements, a variety of things like that. What was fascinating to me is that they were required to track all the way back to every single metal component, to track it all the way back to where it came out of the ground, every single step along the way. But they were required to keep track of it. They were required to have those records, and there was periodic requests for those records, but it put then, instead of us having maybe an expensive software system to instead maybe use that kind of a model. And I don't know enough about your software to really speak very intelligently about it, but it was just interesting to me that even in the making of parts that would be used for surgical implants, that they had to track it all the way back to the mine.
Thank you, Senator Kiffmeyer. Further questions or comments to the report? Senator Nelson.
Oh, thank you, Madam Chair. Commissioner, I can't re-find it in the documents here, but maybe I misheard. I thought, or maybe it was the Office of the Legislative Auditor discussing that there was a time when a client reported an adverse reaction, and it appeared that there was a lack of control in the potency of that medical cannabis. Did I understand that correctly? And I don't see that in any of this documentation, but to me that sounds like one of the most serious concerns if there was not a control on the potency of the medical cannabis. I'm wondering who might be able to address that.
Ms. Bombach?
Madam Chair, Senator Nelson, I did bring that up. It is, we do talk about it in the report. I think the department can relay the details, but essentially it's my understanding that the patient had an adverse reaction and the manufacturer was, basically there was an administrative penalty because after the fact the department identified that the product didn't go through appropriate testing.
So,
Senator Nelson.
Madam Chair, I would just like to register that I think that is a major problem. If you're going to a medical cannabis laboratory to get medical cannabis, and yet the drug has not been put through a regulatory process that would ensure its potency, that's one of the basic key elements of any medical drug, is being assured what that potency is. So I would want to know how that happened and what's in place so it does not happen again.
Commissioner, if I could, and then Senator Jensen.
Thank you, Madam Chair. Senator Nelson, I've asked Ms. Volkes to respond to that.
Welcome to the committee. State your name and proceed.
Thank you. I'm Chris Thokas, and I'm the Director of the Office of Medical Cannabis. Madam Chair, Senator, we very much agree with you that that is a serious problem. We do require the laboratory testing, and so in that particular instance, that was a violation of our administrative rules, and we did take enforcement action. Right now, with the current system that we have, it is very similar to what Senator Kiffmeyer described, in that each of the manufacturers have their own seed-to-sale system. The state does not have a seed-to-sale system. With a centralized system, we would be alerted when things like that were happening, and laboratories would be reporting to us directly. As it stands right now, as the enforcement authority, we go out and request periodic information from the manufacturers. And so that is our current system. And we do have standing adverse event reporting for patients. And so that was an actionable offense.
Thank you.
Thank you. Thank you very much. Ms. Bombach, I don't think we have anything further from the committee with regard to the audit findings. I'd like to move on to the process for adding qualifying conditions. And members, this rose out of some concern I had about the addition of macular degeneration as a qualifying condition. And so we are going to have direct comments about that condition, and then we'll call up Dr. Timothy Olson to talk about the Minnesota Academy of Ophthalmology's response. So if you could, Commissioner, please proceed.
Thank you, Madam Chair. Yes, I appreciate the opportunity to discuss an important part of this process, how it is that qualifying conditions get added to the list, but beyond those originally specified by the legislature when the law was first passed. The process basically works like this. Any person, whether that's a patient or a provider or an interest group, a researcher, may request the commissioner to add a qualifying medical condition, and that happens one time each year. Those petitions are accepted in June and July of each year. And the statute specifies that the commissioner must reject a request to add a medical condition or delivery method that has previously been considered and rejected unless the request contains new scientific evidence or research or describes substantially different symptoms. So oftentimes we will get repetitioned for something that's previously been reviewed. We do not spend additional time re-reviewing the same condition unless new information is presented. The commissioner is required to appoint a medical cannabis review panel, which the statute specifies is composed of 7 members, including at least 1 patient advocate, 2 practitioners, and 1 with expertise in pediatric medicine. The review panel assists in reviewing these conditions and reports to the commissioner on what the review panel sees as the public health impacts, including therapeutic factors and known potential risks of the proposed additional medical conditions. In addition to what the review panel discusses, our staff does very careful as they can, literature reviews on are there published studies particular to a condition or a delivery method. And a major overarching constraint on this whole process, of course, is the federal Schedule I status of marijuana, which prohibits there being really strong clinical research at the federal level. The review panel has to meet at least 1 time each year and allow for a public comment process, then must issue a written report to the commissioner by the 1st of November, which again must include the potential benefits and risks of adding or rejecting the proposed qualifying condition. And upon receiving that report, which again includes a thorough literature review by OMC staff, the commissioner must render a decision by December 1st. So this year, there were petitions for a number of conditions and 2 conditions and new delivery methods as well. Chronic pain was also added as a qualifying condition after this review process. But the case for adding age-related macular degeneration, I think the review committee and I, as I looked at the evidence, was not as strong as the support for adding chronic pain. The science relating to cannabis as a treatment for AMD is not as developed as it is for pain, and there's certainly not as much agreement around its potential efficacy. However, we didn't see any indications of specific harm related to AMD and cannabis. Most of the testimony that we received during the process was in favor of adding AMD, although written comments on behalf of the Academy of Ophthalmology did oppose it. And I will certainly be happy to state that since December 1st, after the decision was announced, we've had significant additional dialogue with the Academy of Ophthalmology with significantly more specific and detailed clinical information brought before us. And so that's I think, relevant here. During the process, the exchange was fairly minimal, and we have enjoyed robust discussion with the Academy of Ophthalmology since then. So granted that there's not evidence that cannabis helps AMD, and we didn't, in the review panel, did not claim that there was. However, we didn't see a case that it would be dangerous, and the thought was that medical cannabis would provide another treatment option for these conditions for which the treatment for one group of types of medical cannabis is a difficult treatment, and for the other, treatment is more lacking. So that was the thought process was, it's not unlike other conditions in which there's thought to be the potential for benefit, no definitive proof, although the observational studies that we have done in the medical cannabis program in Minnesota, we think do add helpful information to the emerging understanding of the potential therapeutic effects of cannabis for pain, nausea, cancer, other conditions. Another thing, actually, the auditor mentioned, the importance, the centrality of this feature of our program is that patients are required to have a relationship with a provider who certifies them for the program, certifies that they have one of these qualifying conditions, and that provider is agreeing to be in a treatment relationship with that person. So for us, that's a really important piece of context, that we're relying on that individual provider-patient relationship. And we really view this as not unlike other therapeutic decisions between providers and patients. So we view our role, or I view my role, I guess, as the decision maker here, as simply deciding what should be a treatment option, not in any way endorsing it or recommending that it should become the standard for treatment. So that, I think, is just all I would say sort of about the process and the context. I know you're eager to hear from the Academy, and then we can perhaps have more discussion that you might wish to have. I would just state before concluding that I think we are at a point in the growth of the program where, as we think forward about what's the role of the condition review process, it really does kind of call into question some really fundamental thoughts. We certainly could build tighter controls into the program in terms of requiring a greater degree of involvement from providers. We could add much more complexity and specificity to what subsets of certain conditions might be qualifying conditions, but not the entire cluster of a condition. Or we could kind of go the other way and say, really, this is a matter between providers and patients, and the department doesn't play a value-added role in the review of conditions. I think our point is we take pride in the fact that we intend for this to be a scientifically based, carefully constructed program. We think we've learned an awful lot in the 5 short years of the program's operations, and certainly are open to further discussion about how to improve the process going forward. Thank you, Madam Chair.
Thank you. And Dr. Timothy Olson from the Minnesota Academy of Ophthalmology, welcome. And please proceed.
Madam Chair, for the record, I'll mention that I'm Dr. Jeffrey Emerson. Dr. Olson is in clinic today, and I'm filling in. I'm from Phillips Eye Institute, where I serve as medical director, and my practice focuses largely on the treatment of macular degeneration and other retina conditions. On behalf of Minnesota Academy of Ophthalmology, and there are about 450 eye physicians and surgeons in Minnesota, thank you for the opportunity to speak today. Our concerns are with adding macular degeneration to the list of qualifying conditions for the medical cannabis program in Minnesota. But please note that these comments are in no way related to recreational cannabis or any other qualified diagnosis other than macular degeneration. I'll speak about a minute on what is macular degeneration, about a minute on the treatment that we currently do, and then a minute or two on cannabis. Age-related macular degeneration affects more than 200,000 people across Minnesota and is the leading cause of severe permanent vision loss in individuals over the age of 65. Macular degeneration causes loss of central vision. It's gradual over years. The vision loss is particularly noticeable for reading, recognizing faces, and driving. In the case of dry macular degeneration, the early stage, it's a rather slow process over months or years, but with wet macular degeneration, it can be very rapid over weeks or a month. Over the past 15 years, there have been 4 new medications called anti-VEGF agents that have revolutionized the treatment of macular degeneration, making what was before largely a hopeless condition now treatable. And in fact, 90% of people receiving anti-VEGF treatment for wet macular degeneration do not lose their vision year to year. And for half of those patients, there is actually some vision improvement. And this is very different from 15 years ago before the anti-VEGF medications. But there are well-established treatments with clinical evidence over a wide range of treatment options, including vitamins. Eye vitamins are quite effective in preventing macular degeneration. Smoking cessation, exercise to control blood pressure, and even diet modification. Diets rich in green leafy vegetables like spinach, broccoli, kale. This broad range of treatments is well supported by evidence, and in fact, a Medline search of macular degeneration and treatment will yield about 20,000 papers. By contrast, there is no evidence that medical cannabis is helpful for macular degeneration patients. And we were surprised to learn last year that about the petition to add macular degeneration as a qualifying diagnosis. And then further surprised after we had opposed it that it was put on the list. The Minnesota Department of Health did cite 6 studies in their brief on the cannabinoids that are in preclinical realm for macular degeneration. These studies are largely not relevant to humans with macular degeneration. And in one example, the research was in mice that were exposed to bright light to create a retinal degeneration. And then the electrical response was measured in the retina. And when a drug was used, there was a slightly better electrical response, but the drug was not a cannabinoid. It was an agonist of a receptor that binds to cannabinoids. And I'd also like to mention that mice do not have maculas and they don't get macular degeneration. So we're a long ways between the research and the actual patients in this particular example. And the other examples also do not create a basis for using cannabinoids in macular degeneration patients. In addition to the lack of evidence, we're also struggling with the idea that there can be a list of 14, 15, or 16 qualifying diagnoses, and then the other diagnoses, the rest of medicine, is not on the list. But we're not. But the Department of Health is saying that they are not endorsing or recommending this treatment in those diagnoses. It looks like there is some sort of a sorting process, and certainly the experience we're having with our patients is that they do interpret it as a recommendation from the state. They are coming to us asking, what is the evidence? Should they be on it? We appreciate Commissioner Malcolm and others at the Department of Health for their willingness to sit down with the leadership of our organization to talk through our concerns in the past few weeks. Unfortunately, the department has indicated to us that they don't have the ability to remove macular degeneration from the list of qualifying conditions, ultimately leaving the decision in the hands of the legislature. We're frustrated how we got here. There were 2 comments in the petition that were in support of the adding macular degeneration. In both of those cases, the macular degeneration was paired with chronic pain, and macular degeneration is not painful. There is no pain with macular degeneration. Madam Chair, thank you again for the opportunity to share with you and the committee members more information about macular degeneration and our concerns for it being added to the list.
Thank you very much. Senator Jensen, and then Senator Matthews, and Senator Klein. What I want us to do is, it's been a while since we put the Office of Medical Cannabis into place. We've seen there need to be some operational reforms, but I'd like us to frame this discussion to help us figure out if we need to do legislation or have some authority in circumstances like this. So transparent discussion, there's no language before us. So this is about developing ideas and policies so the commissioner and the medical community can give us good advice. So Senator Jensen.
Thank you, Madam Chair. Thank you, Doctor, for being with us, and thank you, Commissioner Malcolm. I really don't want to come across as an apologetic for using medical marijuana for, if you will, age-related macular degeneration, but I do think there's a couple things worth noting. One is I believe that the NNT, the number needed to treat with Lucentis, requires 24 injections before one person will benefit out of 3. So 70% of people receiving 24 injections of Lucentis will not get relief. And the Lucentis injections are quite expensive. In addition, I think that we have Avastin, which is perhaps a digression, but I think that when we look at the cost, that's problematic in and of itself. I also, being married to a veterinarian, I do know that oftentimes in the world of human medicine, we assume that animals don't get the diseases we do, but oftentimes we find that over time that's not the case. And so it's possible that in a decade or two we might find that mice have macular degeneration. Perhaps they won't tell. But I do think that we need to be sensitive to the Department of Health. I think you're working hard trying to appropriately administer a program such as this, and you go through a process. And while the process may not be perfect, I appreciate it very much. And I did read the 6 identified articles that came out with your decision. I also called multiple ophthalmologists on my own just to ask them. And their feeling was, we really don't have a lot to offer. And most of the time, many times we're talking about people in their 9th or 10th decade of life. And they said, probably not much harm to it. And there is an endocannabinoid receptor system in the retina, so it's possible that down the road we might find that this could help. I sort of feel like we have the same situation going on with dementia. We have some just putrid, unsuccessful, very expensive, highly toxic medications that are being used for dementia. And it's like, well, we don't have much else to offer. People don't want to just slowly get demented more and more. And people that are losing their eyesight, age-related macular degeneration, quite frankly, it's not a very good prognosis for some of those folks. And so, to me, you made a decision in part because you looked at no harm, no foul, primum non nocere, first do no harm, and you made your decision. Now, again, I'm not going to get deep in the weeds with an ophthalmologist who's far smarter than me. But I'll say this. If we, as a legislature, would use this as some sort of rationale for us to take a more active role in scientifically deciding what diagnoses should be eligible for medical marijuana, I think we'd be going down the wrong road. If we ask the Department of Health to say, could you help us understand the metrics you use? Is there a process improvement that could be made? That's fine. But I would caution the legislature because too often, we go outside those guardrails. Thank you.
Senator Matthews.
Thank you, Madam Chair. I don't have the medical doctor experience like Senator Jensen or others and won't pretend to. But I do have a question, Commissioner. In going through the slides you showed, you pointed out the scientific research that you use as your criteria all over slide 15, 16, and so forth, and then came down to slide 18 saying that the support was not as strong and most of the testimony you got was in favor of it. And it just seemed like a disconnect to me. Is there more public opinion being the driver behind the decisions than we're being told, or isn't it? And would you be supportive of a legislative effort to give you the authority to reverse decisions or support a legislative decision to reverse this particular case? Like, where can we go from here? What gives here? What's the disconnect?
Commissioner?
Madam Chair, Senator Matthews, thank you for your direct question. I think actually Senator Jensen described the conundrum really well, that it did, we really were not attempting to say, we think the evidence is there that this is beneficial. When I said this was less of a clear case, there was less literature, less hypothesis of the potential benefits because of the cannabinoid system in the retina. It is possible, but as compared to some of the other conditions we've looked at, where there's a body of experiential evidence at the very least, if not randomized clinical trials, that there is benefit, that case was not as strong in the case of AMD. So it really kind of was about the age of the patients, the difficulty of the other treatments. Quite honestly, what I think the conversation since the December 1st decision, much more detail has been offered about the effectiveness of vitamin treatments and other things, the rapidity of decline. The concern that the ophthalmologists have raised is that if folks pursue medical cannabis as a treatment option in lieu of some of these perhaps more difficult or costly treatments, that it could be costly in the sense of delaying their accessing other treatments with potentially better better effects. I think Senator Jensen, as usual, kind of can condense the kind of the numeric percentages into still not a great option for a lot of people, but. I honestly want to share with you that I think the dialogue we've had with the ophthalmologists made me a little more sensitive to the potential risk than just on the basis of the letter that they had filed during the petition review process. So in all honesty, I would not be opposed if the legislature decided that you were uncomfortable with the addition of this one. We did take a look at whether our understanding of the statute and the rules would allow me to just revoke a decision, and we concluded that I did not have that authority, which makes it something that we would, our belief and our thought was that this would, the process was designed precisely for this, so that there's a period of time for the legislature to hear other concerns before this would take effect next August. This is the period of time in which this is designed exactly for this, for the legislature to strike a condition from the list.
Thank you. Senator Klein and then Senator Nelson.
Well, thank you, Chair, and thank you, Commissioner. Fascinating discussion. Thank you for bringing this to the committee. And Senator Jensen makes some convincing arguments, as always, thoughtful arguments. But philosophically, I'm going to disagree. This sort of approach that can't hurt might help, so we're going to give it our Department of Health imprimatur, seems sloppy to me. And Commissioner, I don't envy you having the position of making these decisions. So I don't say that as a reflection on this decision or any decision. But in terms of medical care for us physicians or anyone at the Department of Health on any medication, not just cannabis in macular degeneration, it seems to me we should be able to tell our patients more than just, there's not much else to offer and this won't hurt you. I think patients have a higher expectation of that. The letter from Dr. Lawrence is quite compelling in this regard. I'm just going to read one sentence from it. Including AMD as a qualifying condition is anti-science, medically incorrect, and brings a risk of causing needless blindness. And the last point is notable not only because patients, as you say, may defer more appropriate treatments, but that further research into the illness itself may be forestalled if people feel there's this easy, inexpensive, and non-harmful procedure they can undergo. So I think I would support reversing this as a qualifying condition, and I would support us describing more for the benefit of future commissioners what we expect out of approving certain conditions for this program.
Thank you, Senator Klein. Senator Nelson.
Thank you, Madam Chair. My comments are somewhat along the same lines as Senator Klein's. It's worrisome to think that we would say, well, it can't hurt you, so now it is an allowed condition for, or an allowed medical cannabis, use for medical cannabis. So, and I appreciate the fact that you've been very clear about this particular situation and the difficulty in which this decision had to be made. But it occurs to me that there's just a couple instances as we discuss this. One, there's the lack of randomized clinical trials. That's the gold standard. That's what we expect when we are seeking medication for some diagnosed condition. We don't expect to just get no harm. We believe, and when we talk about medicine, there's been randomized clinical trials that show some form of efficacy. And I think that's a problem, not just with this particular situation, but with the medical marijuana program in general. We don't have those randomized clinical trials. And because the feds have, this is a Schedule I drug. There have been none, which every year I ask the feds through a resolution to allow research. So we get the data we need. So we're kind of operating in the blind here. I still believe it's a little bit of medical Wild West, not having randomized clinical trials, and the physicians don't the physicians do not prescribe the medical marijuana because, well, their licenses could be in jeopardy. So we have to be clear about that. And so I did want to ask about, you mentioned that the physicians have some sort, or the patient has some sort of role with a treatment role with the physician. And I did not know exactly what was meant by a treatment role, and what does that mean? Because clearly the physicians diagnose, but in the case of medical marijuana, they do not prescribe. So what does that mean that they have some sort of a treatment role?
Commissioner.
Madam Chair, Senator Nelson, you're absolutely right. I mean, the federal prohibitions on research are a major constraint on our ability to give you better answers about what we know and what we don't know. Again, I'll just say that there's been a lot of observational research, including here in Minnesota, about benefits that both patients and providers perceive from their patients' use of medical cannabis. But the fact that its status as a medicine is as murky as it is a problem. You're completely correct that because of the Schedule I problem, physicians are not prescribing. It's the pharmacists who are doing the dispensing. But the physicians must do two things. They must certify the physician or other qualified provider, can also be a physician's assistant or a nurse practitioner. They certify that, yes, the patient has this condition, and I have a relationship with this patient. So they're not prescribing it, but they're saying, I'm not just walking down the hall handing out this certification. I am in a relationship with this person. So that's the intent. Now, it'd be fair to ask, how do we test that? And what kind of provider is it? Because that's been another suggestion. It's like, well, gee, maybe it should have to be an appropriate specialist that was doing the certifying of these conditions, which would be, a significantly more complex kind of regulatory regime than what we've got set up today. But that is certainly something we could consider if that was our desire, to kind of raise the bar, if you will. But hopefully I answered your question.
Yes, and Madam Chair, just my final comment, thank you. But with all this murkiness and not having the gold standard that we attach to prescriptions, medical prescriptions, and with the situation that we've had today here with the adding on just your shoulders of the macular degeneration, as we go forward, I understand there's the legislature needs to withdraw that as a qualifying condition. It also seems to me, though, that this is something that the legislature should do in the first place. As far as adding additional qualifying medical conditions, we just don't have the science and the data that we need really to make these adding additional conditions. So just to put that on the record, I'm cautious about the murkiness of this entire situation at this point.
Thank you. And Senator Marty.
Madam Chair, I think Senator Nelson made a good case for, as I think the Commissioner mentioned, for removing this from Schedule 1, at least in our state classification of it, because it's going to continue to be murky. I really dread the thought that the legislature is going to try and get into all these things and try and make these judgments. And I actually think, again, I know 1% or 0.1%, as much as Senator Jensen and some others do about this, but I do think he put it in perspective about when you look at the alternatives, you look at the situation. I don't think the commissioner's decision was an irresponsible decision. Whether that's the one that members of the legislature would agree with or not, I don't know. I do worry about the direction we will head on this, and I do think that we'd be a lot better shape if we were to at least push ourselves to remove it from Schedule 1 and push the federal government to do so, because I don't think we're going to get a lot more evidence. I mean, we're slowly getting little bits, but it's going to remain murky until we have more chance to do the research.
Senator Jensen.
Thank you, Madam Chair, and thank you again, Doctor and Commissioner. It seems to me that the randomized controlled studies that Senator Nelson speaks to are exactly what we'd like, but exactly what we can't have. And I think if Minnesotans look at us and watch a hearing such as this and are confused by our lack of willingness to have robust discussions about the role of medical marijuana in people's real lives, they should be confused. We haven't been willing to discuss it, talk about it, consider rescheduling it. And so here we sit. I do think that it's important for people to realize that you're going to get the good randomized controlled studies when you've got high-powered, big-buck drugs. And when Lucentis was released on the market, it made in sales $4 billion the first year. And if ophthalmologists choose to inject Lucentis versus Avastin, it's substantially more lucrative in the office as well. So they've got all kinds of forces pushing forward. Plus, Lucentis has indications that Avastin doesn't have. So there's a distinct possibility that Lucentis may indeed be a movement forward in terms of quality treatment of a patient. But when you have all these things going on, and then we've got this marijuana program that's just floundering, and we're trying to make it better, and we have the Office of the Legislative Auditor trying to help us. I think we're getting exactly what we've asked for, and we've tied your hands. We've not let you put the kind of rock-solid program in place that you might like to. So my hat's off to you, Commissioner Malcolm, for doing what you can.
Commissioner, any closing comments?
Madam Chair, members, thank you for your thoughtful engagement on this. I do think, we're 5 years in, we've learned a lot. Again, I would just tell you that we hear from an awful lot of patients and an awful lot of providers that this has been of real benefit to their lives and to the outcomes they see in their patients. It's not a randomized clinical trial, but we have published out of our office some very interesting experiential data that others are looking at with great interest. The study on PTSD and pain in cancer patients, I think, has added substantially to our understanding of the potential of cannabis as medicine, and certainly it's been viewed as a medicine for millennia historically. So it is a conundrum, just given the federal treatment of the topic. But I think we have done a credible job of building a much more rigorous program than exists in most other states, and that is part of the critique of the program is that it is more restrictive than many, and more costly, and that's because we've chosen to build a pretty tightly controlled model, and that has its benefits as well as its detractions.
Thank you, Commissioner. And members, we have a clear disagreement on this committee as to whether or not the legislature or some part of the legislature should insert itself between an approved medication and patients' access. And so when it comes to how the Office of Medical Cannabis will operate. And as we have scope discussions, what is our role in how we regulate health professions and how we regulate patient access to medications is going to continue to be a rigorous debate in the legislature. I would ask you to think about what you've heard today, reach out to the stakeholders, the people who run the labs, who run our GROW programs, the ophthalmologists in particular, so that as legislation comes forward, this isn't partisan, it is a debate about where this program goes. And I thank you all for your attention. I thank everyone for being here to help us make these decisions. And with that, members, we are adjourned.
Thank you, Doctor.